So good afternoon everyone สวัสดีครับทุกคนครับก็ for this afternoon I'm Dr. Tim ภักพลอิสระไกรศิลป์ from Bangkok Hospital. It's a great honor to be invited here to share experience about Region 10 and thank you the faculty and also สวัสดีท่านอาจารย์ทุกคนนะครับท่านอาจารย์เอกวิทย์ประธานนุสาขาด้วยนะครับ So for my case, we talk about partial tear. I think partial tear is also sometimes tricky and it may be borderline pathology that we have to decide what is the good option for each patient. It might be partial, but it might not result in the good outcome in every case. So for the partial tear, I think the case that I will share quite similar to Professor Sugaya presentation because I have concern or I have like a complex decision to decide in calcium deposit or calcific tendinitis case. In this kind of patient, when we do surgery, they usually had several injection with cortisone already, so it might cause the tissue problem. And also from MRI, we cannot evaluate the cuff integrity well. Sometimes it looks okay, but sometimes when we go inside and we divide the calcium and it's not a good tissue or it leaves a big defect. Similar to this case, you can see when we remove the calcium, we try to divide the calcium. I also have question and I think everyone have question that, okay, should we divide the tissue and calcium alone or should we do repair? Or side-to-side repair, it would be enough or not. Let's say in this case, when we divide and we can see that the tissue quality leave a defect inside and it quite huge defect and this might not be a good candidate to do side-to-side repair or we cannot reliable on this tissue. I have also experienced in the case that previously did calcium removal without repair and then progress to full thickness tear soon later. So there is also question that we should do bursal side repair or we have to take down for full thickness repair. So I think that is my decision conflicts that in this kind of that partial tear or in calcium case, should we rebuy alone or should we do side-to-side repair or should we do a full double row repair? And I think all options are acceptable, but none might not be matched to every patient. And also, if we look into the difference of the partial thickness tear, there might be a delamination tear which can lead to different biomechanics or bad structural integrity and also poor tissue quality. So let's talk about first case. This is 61 years old female. She has persistent left shoulder pain for more than a year. And diagnosis from the X-ray and MRI, we can see a calcium deposit at the supraspinatus tendon and not improved from injection and physical therapy. Positive Hawkins and also positive Job test. When we look into the MRI, we can see that there are bursal inflammation, bursitis, and big, huge calcium deposit at the supraspinatus tendon. The cuff integrity looks okay from the MRI. So in this case, I plan to do acromioplasty because of the acromion spur and calcium removal and plan for cuff repair if needed. When we go outside, I go and evaluate the articular science and it's intact, then do acromioplasty. And you can see the calcium deposit with the bursitis at the bursa. So it's quite huge calcium. In this case, I try to remove it by create a longitudinal incision. And once we remove, I can see that there is still very small defect at the distal footprint of the supraspinatus. The structural overall looks okay. So I think in this case, most of you may leave it. And same to me. I don't think I need to repair it, but I also create a biologic healing by microfracture at the bone. And also I augment it with the biologic patch because I don't want to overtreat structural, but I want to add the biological healing in this case. And even in like acute inflammation phase, we can see if we clear all the calcium and add the biologic patch, the patient can recover well within 6 weeks. She can recover to full motion and also full power. Another case, quite similar, 60 years old, female, same persistent right shoulder pain for, in this case, almost 2 years. Several injections in the shoulder and that calcific tendinitis from X-ray and also from MRI. You can see from the MRI, quite similar. There is a calcium deposit at the dorsal part of the supraspinatus. So in this case, I plan to do calcium removal and plus or minus cup repair. Again, evaluate the articular side is still intact. Dorsal side looks very good in this image. When I find the calcium deposit and then I create a longitudinal incision to remove the calcium. But you can see that when I try to rebite a little bit, it leaves a big defect inside. So that means the tendinosis may be there. Yeah. So in this case, it leaves a high-grade dorsal side tear with some flaying of the tissue at the dorsal side. So in this case, I think we should repair it to create structural stability. So I put one medial anchor and I do repair the same construct as Dr. Banchal. This case 1, 2, 2, 1. And with the soft anchor, you can see there is some blood clot there to add biologic. After repair, I check the inside first that I'm not violate the bicep, and then add lignoten to support the tissue integrity. So repair alone in this case may heal, but I want to reduce biological failure risk in this case as well. And I have one question that we'll leave to the panel later. For this kind of surgery or additional of biologic patch, do you adjust the rehabilitation protocol? Because for me, I still use the same protocol in small tear or massive tear. And she recovered well. I did not have the follow-up MRI. And the last one, 57 years old female, again, persistent left shoulder pain. This is different. This is high-grade partial tear of the supraposterior cuff. Yeah, and not improved from the PT with positive joint pain and weakness, and also Hawkins. So from MRI, even not nearly full thickness tear, but not a big tear, not much retraction. But you can see if we measure AHI, it's very small, 0.3 centimeter. So for this case, I'm quite concerned about the tissue quality of the cuff. And also she had a history of another shoulder, 3 times surgery of the rotator cuff repair and end up with SCR. So I think for this side, it might end up the same with the tissue that's quite thin. So I go inside, is bicep looks okay, evaluate the articular side, looks not a huge tear. I do convert it to full thickness from the articular side. And then again, acromioplasty if needed. And after debridement, you can see, after takedown, you can see this kind of gap with the tissue. Not a bad tissue, but fraying and also thin tissue. I do double suture bridge repair. Yeah. To repair this one, I need to check that we can get the inside layer or the capsule layer and get the good suture bridge repair. And you can see the tissue is thin and fraying. So when I check inside first, because I try not to evaluate the patch after we fix it. And then I put the lignoten patch above the repair site. Actually, I asked for the big one, but unfortunately, I get the small size of the patch. So it looks small and a bit low to me. In this case, I do have a chance to send MRI 4 months, so we can see that there's increase of the HI distance from 3 millimeter to up to more than 7 millimeters after repair. And when you evaluate the MRI, we can see that the cleft integrity is still preserved. Not the best healing yet at 4 months, but still preserved and good function. But I think if we look at the patch, at the signal, it might be there. Also, another question to the panel. For me, from this case, I change or I adjust technique a bit to apply it more medial to cover the type 2 re-tear or cover the medial notch, because I don't think we need to cover the whole area of the lateral lobe. Okay, so for me, partial tear may be also tricky and complex in some case. And in case of the poor tissue quality, we can add biological augmentation by adding the regenetin. Thank you so much.
Thank you, Dr. Phakapon. The next session is the case sharing by Dr. Lathapoom in the revision case with regenetin.
Good afternoon, everybody. Thank you for having me in wonderful symposium. My name is Dr. Rathapoom Vachorapat from Vethani Hospital. Today we share a case with a revision rotator cuff repair with regenetin. So,มันไม่ขึ้นตรงนู้น ขอสไลด์ด้วยนะครับ Okay, my case is a 64 years old male person with 2 weeks history of the progressive left shoulder pain. He had a previous rotator cuff repair 2 years ago. Proactively, he developed pain after ATV driving and MRI showed a partial re-tear. He was treated conservatively with a good improvement and returned to his home country. But now he remained as asymptomatic until 2 weeks ago when he developed recurrent left shoulder pain and present for evaluation. This is the first MRI at the first operation. It show about the complete tear of the supraspinatus and infraspinatus with, I think it look like the L shape with Gruyere 1 or 2 and PET 2. So intraoperatively, we found complete torn, and I did a double row knotless transocean technique with subacromial decompression with bicep tenotomy, and we can cover. And this is the MRI post-operative at the 2 weeks. It demonstrates a minimal partial torn of the supraspinatus, and I decided him to treat with conservative treatment, and he report improvement and return to his home country. But now he come with a progressive, with a 2 week history of progressive pain of the left shoulder. From examination, we found that he had tender at the greater thoracity and full range of motion with painful arch, jaw positive, and neurovascular intact. The MRI for preoperative showed about the return of the supraspinatus, infraspinatus is look likely PET 2 retraction, and I think it look likely posterior L. Gutteri is still good, no second atrophy. The subscap is still good. So for conclusion, in this case, a complete re-tear of supraspinatus and infraspinatus, I think is repairable because there is no osteoarthritis, PET 2, Gutteri 1 or 2, and still non-atrophy. So I set operative for revision arthroscopic rotator cuff repair with region-10 augmentation. The challenge in the revision case is that it high return rate, the poor tissue quality, and limit biological healing. So I think in revision we need the biological augmentation. But for about the regenerative bioinductive implant, it can promote tendon healing by inducing new tissue formation and increase tendon thickness. It shows to reduce return rate, as I highlighted by Dr. Channon said in the morning. And about the evidence, in the recent evidence revision case in the prospective control study, probably in this year, include 21 revision with region 10, it showed a return rate about 28.6% as 1 year from MRI. So that means more than 70% is still intact on the MRI, and it's around with it can significantly improve of the functional score and reduce the pain. So in revision case, I will consider region 10 is indicated in the patient with poor tissue quality and large but repairable tear. And the contraindication is that irreparable tear or S1 cup arthropathy. So I think in this case, it's suitable for region 10. Intraoperatively, in articular evolution is shown about the return and the footprint with intact about the suture ankle. In subacromial space, it is shown of the compact tear pattern. And we remove most of the previous suture and divide the rotator cuff to a stable rim, and followed by the footprint preparation by cleaning or residual tissue as shown in this video. After that, the rotator cuff tear pattern I show in the video, it looks likely the posterior L, and we simulate the direction of the tissue reduction to plan anchor and suture placement. And we plan to double row tunnel shear repair the medial placement is shown in this video, and I did the microfracture to perform the footprint enhancement biological healing. The suture tape and high strength suture were placed at the show and the picture. And I did a side-to-side suturing to perform the convert posterior L into the U shape, and followed by a simulation about the lateral placement, and the scene construct and determine about the lateral low. After insert, one lateral anchor, most of the rotator cuff was able to cover about the footprint. And next step is regenerative augmentation. Before regenerative insertion, you need to define the most medial and anterior margin. And I use the needle insert into the rotator cuff as the reference, while I use the probe from the posterior portal to determine the most medial of the implant. And this video show about the regenerative implant that insert. You can see about the position of the implant from the medial, and it can expand and do a cover about the repair rotator cuff that we plan. After that, I press about the medial ankle and start for the anterior, posterior, middle, and I make sure that it stable, and I use the probe to help to remove about the stem, and then I put the lateral at the picture. This is show about the final result of the regenerative augmentation. And for the outcome assessment, I did the MRI at the 2-week postoperatively And for the coronal view, compared to actual, I think it can cover most of the footprint. And this is a sagittal view compared to pre and post operation. And after he did the field therapy, he report improved in pain and improved range of motion. And he achieved full range of motion about 3 months. The functional score, ASES functional score, demonstrates significant improvement compared to the pre-operative value 3 and 6 months post 1 year score is expected next month. In summary, degenerative augmentation in revision repair is promising. It is safe, also it low complication rate, and provide improvement in tendon healing, clinical function. But however, it's not a definitive solution. Selective, appropriate patient is crucial to maximize the outcome. And I really thank you for my teacher, Dr. Up, to make this case successful and good result at this. Thank you.
Okay, the next one will be the case sharing by Professor Bansha.
Okay, good afternoon. So I'm talking about the case sharing in the complicated rotator cuff tear. Okay, so we have the first patient. This is my first patient. Actually, I don't believe at the beginning because they say this is a magic patch. I don't believe that there's some magic patch in this world. So until one day, I have this patient. I did the subscap for her 5 years ago. She's very active. She's 62, and she has good subscap and bicep tenodesis. But 5 years after that, she had this supraspinatus. I think his cup is look very degenerate, right? And I'm thinking about, may I try to use this magic patch, okay? So this is her tendon, right? When they get in, I found that the tendon look very degenerate, right? So I take down the cuff, but I found that the cuff quality is not so good. I make a suture bridge, right? And then we put the regenerator on the top, okay? So her subscap is still good and bicep, right? So that's my first. I always use the big size. That's a small size and big size. I always use big size because this is expensive patch. Yeah, I feel like I'm happy to make it bigger. So this is the first case and she's happy. We have very nice healing after that. This is about 6 months. Yeah, the tendon get thicker. So from the current literature, they found that the thickness will be increased about 2 millimeters. Yeah. So the quality tendon is good and the patient doing well. So after that, I start to do more and more. So my technique, I add my needle puncture because I want to have bleeding because Shannon talked about regenerator this morning. You need to have cells into the regenerator. So I always make this trephination in my cuff. Okay. So after that, this is a second patient. Yeah. So she had bad cuff, and I get in. I try to do really minimal invasive. I just make side to side. I will not take down the cuff. Okay, and put the regenerator on the top. So actually, this is my second patient, right? So after surgery, I did not cover to the lateral, like Tim asked me this morning, right? Sometimes I did not go to the very lateral because the attachment is good. The problem is on the more medial side. So my goal is to stimulate the healing on the tendinous part, not at the footprint, right? So after surgery, the patient doing well, yeah. But I found that patient have some inflammation during on the way, yeah. And comparing to my general rotator cuff patient, I found patient have more inflammation and sometimes very painful, right? But finally, it's good. Finally, we get very nice tendon healing after the surgery, right? This my friend, he's 55 years old, yeah. So his rotator cuff. It's not tear, but you have you see the MRI have intratendinous, okay, of the rotator cuff, and he's quite painful. I did not take down his rotator cuff. I just do trephination, did not take down anything, and put the patch on the top, right? This is abrasive tear and intratendinous. Yeah. So actually, in Geniten, we start the first paper talking about bursal site. But nowadays, like Hiro Sugaya told me that he have extended indication for revision, for calcific tendinitis, there's extended indication. So you see the MI, his MI look nice after the repair. You cannot see the patch anymore because over time, the patch resolve and become the scaffold for the new tendon, right? So this is most of my patient is this tear, is we call the bursal site tear. The bursal site, you can have abrasive tear, you may have flap tear. I think flap tear outcome is very good. You have good tissue to cover the footprint, okay? And this is the flap tear, yeah, the healing is okay after the surgery. This patient, at that time, I have no Regeniten. Her tear called racket. Racket means dirty, very like comminuted tear of the tendon like this. So you see the tear is look bad. So at that time, I don't know how to do that. I just repair this bad tissue to the tendon and try to make suture bridge like that. I think this is bad. Patient not happy, not happy. MRI after surgery look the same like before, okay? So they's not happy. But anyway, she come back to me again for the opposite side. She said, I'm not happy, but it's good enough. So this time she come back the same way. Yep, very bad tear, racket, very thin. You see that? I did not touch her tendon at all. I just make side to side. Did not put any anchor, just make side to side, and then we cover with the patch, right? So this time she's very happy and the healing. And she said this time the recovery is faster because I did not do any takedown. I just cover the patch, yeah. So this is another patient. He's have the type 2 tear. I think the type 2 tear also another option because you know that the type 2 healing is not so good, right? So I just make like Ajahn Ekawit, we did not tie the knot at all. Yeah, we just cover the apex of the tear and then put the Regeniten on the top, right? And the patient have nice healing after the surgery, right? So this is a type 2 tear. I did not go that far to the lateral team. I did not go that far. We just cover on the type 2 tear, right? So this is another indication of mine is a massive. Yeah, this is have subscapularis and also supraspinatus. So we spend a lot of time for the tissue preparations. So we start the subscap first, followed by the supraspinatus, okay? So that is supra and also the subscap, okay? And then we put the Regeniten on the top, right? At the rotator cuff. And the healing is also nice, right? So for the revision surgery, this patient, I did the surgery for him 10 years ago. He's doing well. Yeah, and after that, he come back with a tear cup again. So the cup quality is not so good. So we performing the suture bridge repair, less knot tying, Regeniten on the top. Okay, and this is after the surgery. This is about 4 months. And you see the tendon before the surgery and after, we get the thicker tendon, good quality, right? So this is another patient. She had very bad tissue quality. She has done rotator cuff repair before, but the first doctor did not decompress the acromion, right? Yeah. So I think you should try to look at the loop always when you have the bad tissue. I did not touch her rotator cuff. We just put regenerative on the top, right? And decompression and bicep tenodesis. So that's what I did. And this is 6 months after the surgery. She's doing well, and you see the quality of the tissue is getting better, right? So another effect of regeneration, I will tell you. First time I heard from my fellow Chanon. Chanon said, Prof, I have problem. My patient not happy because after surgery, they got swollen. And he thought that it's an infection. So he aspirate and also sent for culture that's negative, okay? But finally, the patient doing well, right? So I think this is another side effect. We also talked to Hero. He also have some problem with that, yeah? So it's not infection. Keep in mind, this is the healing process. There are a lot of inflammation. So sometimes this patient is about 2 months after surgery, I do 1 shot of steroid and the patient happy, right? So don't worry if you have inflammation. If it's more than 6 to 8 weeks from the paper from Dr. Sang Jin Shin from Korea, that's safe to inject the steroid. Yeah. Okay, so in summary, biologic augmentation is beneficial to increase the success of rotator cuff repair, reduce the retear rate, and improve the functional outcome. Okay, thank you.
Any question? Okay,
Any
if
questions?
no, yeah,
Yes,
okay.
up. Bansha. Oh, not me. Oh, sorry.
You should to be in a good rest.
Tim.
Okay, so I would like to ask that the conservative treatment for your calcific tendinitis patient, you think that what is the threshold that, okay, you should have the surgery?
Yeah. So to be honest, I have to admit that in my practice is private clinic, so that there might be lower threshold than normal. But usually, if for my patient, I try to conservative with medication, injection, and also supervised physical therapy for at least 4 months. In my case, for at least 4 months.
I mentioned like this, okay, that's maybe a little bit individual case by cases for this kind of calcific tendinitis. Because of this one, today we're talking about a lot that we have the surgical indication, but actually what is the real state that they need to have the calcium removal? Because of after we open the cuff will have some holes, and the holes cannot be replaced with any good tissue because of the surrounding tissue has been removed as well. So that's why you need some kind of pads to cover that. But before that, I just try to recall everyone that we have conservative treatment for this.
I agree with you. Yeah. So in calcific tendinitis, mostly we try conservative treatment because this is a self-limited disease. The indication for me is that the patient fail. I mean, I try injection, I try everywhere, and the patient still have pain. Those patients always have very big size. You know, they may have repeated resorption. Okay, but anyway, this big size will be there, and you know the pain in calcific is number one. It's very painful, right? So anyway, I try conservative. But in some patients that we have like very big pathologic spur on the top with the calcium deficit, I found that those patients together with the big size calcium deposit, most of them fail after conservative, right? I think that still indicate some indication, but I don't agree to clean, to remove too much tendon, like Hero show you he a bit too aggressive, he clean too much. I think you just make a holes there and use a cullet. Okay, you may use a shaver, but don't remove the tendon too much. Otherwise, you create a big gap, right? Most of the time, we just side to side and maybe regenerate on the top. Yeah.
So what is the science behind the use of Regenerative in calcific? I mean the evidence. If the insurance asks me about it,
Yeah, actually, in my practice, I never tried that before. That's why I asked Hilo this morning, because the calcific tendinitis itself very inflammation is very intense and very painful. You add another regenerative, you may improve. You have more inflammation. Yeah.
Sometimes we found the calcium is invade to the bone at the gather tuberosity, and after we remove the calcium, we found a big hole. I'm not sure what the panelists did do.
I never have that patience.
I see many cases.
in the bone, right? In the tuberosity, right?
Yes, we after we remove the calcium, we found the hole.
I think there is a signal and reaction around the GT, but most of the time I did not do surgery, but it will recover if you follow longer.
Yeah.
Maybe just wait; it will become better. Don't jump to do surgery too fast.
And I will tell you, don't forget to take the X-ray one day before the surgery.
yeah.
Because many times
It's gone.
you get it and you see nothing.
Yeah.
That X-ray was 2 months, 3 months ago, and the patient have so much pain because it's resolved, And one day before surgery,
I said to my fellow,
you always say,
not more than 7 days X-ray.
I think one day before surgery, okay. Otherwise, you get in and you found no calcium. Any question from? Not? หาไมค์ให้อาจารย์น็อตหน่อยโต๊ะนี้
We have time.
We waiting for Hilo to prepare, right?
I think he did prepare. And
can use in pure subscap repair only.
I did that, but I do open because you put the regenerative on the subscap arthroscopic not easy. Yeah, you have conjoint tendon. Yeah, I did that in open subscap repair. I did 2 of them, right? Not easy. Mostly we put it on the supraspinatus because you have enough room.
Just share that one of the
Yes.
surgeon in this world, Dr. Ivan Wong, he tried to repair the subscap and put regenerative,
Yeah.
and I don't know what happened.
Repair and put it in the front, right?
Yes.
I never tried that before.
Just
It should not easy.
search him,
So,
but please be careful about the indication.
So don't. Yeah. Okay.
Question to Dr. Ratapum. Why you do MRI so early? Just 2 weeks post-op.
Because he want to come to this meeting.
Because of he need to go back to home country because he had a foreigner. Before he come back, I want to make sure about the repair and about the regenerative is not pull out or anything.
Okay. So your answer same like Natha. You need to go back to the Middle East, right?
Right.
Yeah.
So we need to do an MRI to
And
make
for
sure.
the first episode of injury after surgery, 2 weeks, he returned to.
Yes, because he had a wife, Thai wife, and go to Khao Kho and go to ride the ATV, and before that the pain improved a lot. But after that, so he said to me that he did ride the ATV and very painful. So I need to do the MRI to make sure it's not totally retorn. That I need to reoperate. But for the MRI show just a partial torn. So I advise him that he can do conservative treatment.
Because of the magic patch.
No, that's the first time don't have.
Okay.
don't have the time.
Can I ask one question to Dr. Bancha? So in the case that it's only the flaying of the tissue or like delamination,
Yeah.
intersubstantial, you put regenerative patch without repair.
Yeah.
How about the post-op rehabilitation? Do you concern?
Yeah,
or
yeah. We
you
did not
sling
immobilize that long.
at all?
No, I sling for 1 or 2 weeks.
Okay.
Yes, just the pain subside, we start to move. Yeah. So I think the recovery is faster if you did not repair. Yeah.
Cannot remember from Dr. Ratapum mentioned how long does it take for the resolve or degradation of the patch?
Shannon talked this
Dr.
morning.
Shannon talk in the morning.
Oh, sorry. How long does it take?
Total is six months.
6 months.
6 months.
Yeah, the scaffold resolved 6 months.
I'm afraid that too early mobilization may let the patch loose or fall out.
Yeah, that's possible. But I think, yeah, it's strong enough. You just passive motion. We check in the data, and it's strong enough. Yeah.
I think Hero is ready, right?
Hero, cannot hear you. Check ฝั่งนั้นดิ
I'm ready.
We hear you
Bancha,
now. Hi.
can you hear me?
Yeah. You have lunch, Hero?
Already.
Yeah, I have.
Okay,
I
good.
have. Yeah. And we have the very nice specimen. This is the right shoulder. Look at this, very nice, sexy, bony blanket.
Uh-huh.
And also, this patient has a very nice heel sac region as well.
Mm-hmm.
So I will show you how to fix my bony blanket. So first,
So, Hero, in your practice, you have assistant arm? You have the assist arm or not? You use your fellow to hold the arm?
Roman Farrell, but today we have the
Shannon.
human spider, Dr. Channel.
Dr. Shannon.
And the Smith&Nephew staff and the sons over there, right? Thank you very much for helping me today. Okay.
Okay, Hero, how many portal you use for bony banca repair?
Bony bone repair, I only use three. Three. One portal, one front, one back, and one under superior. That's it.
Uh-huh.
This is for Hugh-Sachs ramp research, so that's why I need to keep this.
Okay. Okay. So that means you have 4, right?
No, 3. But
Yeah.
The posteral.
So this one,
That's for limb research.
Yeah.
okay, I will show you the front view. Switching stick, please.
So the entry point for the anterior portal is above or below the coracoid process?
This photo?
Yeah.
So no, this is anterior portal. This is a view from the anterior portal. You see the bony banker like this. So always look from the front side, not from the back side as well. Front side, okay? So the anterior portal, I normally place the anterior portal to the interval, but I create the anterior superior portal afterwards. So that's why the distance from the anterior portal and the anterior superior portal is very important. If you create the anterior portal too top, so it's a very difficult to use the two portals. So that's why my anterior portal is switching stick, please. Switching stick. Anterior portal is this is a portal which maybe about from the 5 centimeter from the anterior acromion. And this is a portal, kind of go over the subscap tendon, right? Then I will create the needle, please. Needle. So then I can create the anterior superior portal here like this. So you can understand the distance between these two.
Yeah.
Okay, this is very important.
I agree.
Okay?
So it's just around in front of the AC joint, right?
Yeah. Can I have the, okay. So the rasp, can I have rasp?
Hero, you
So
need
the
5
releasing-
o'clock portal? You need the 5 o'clock portal or not?
So releasing is very important. I already released it. That, this is a bony fragment. And also the release from the superior side of the fragment. And also the inferior side of the fragment. That's very important. The first anchor goes to the inferior side of the fragment. So normally I use the 2 anchors below the fragment. But in this case, this is cadaver, so that's why it is a little bit difficult. So that's why I only insert the 1 anchor below the fragment, like this. My most inferior anchor goes to the 6 o'clock at the face. But today maybe 5:30.
Hero,
Is it okay?
Hero, you need 5 o'clock portal or not? The trans subscap portal, you need it or not?
I never use that. I
Okay.
never use that. Transsubscapular I use only for the repair in the Hagel region. Otherwise, I don't use this.
You don't need that.
Okay, first anchor. Let's go. First anchor. First anchor. Twin fix. Twin fix, not rest. Q fix, not rest.
Q fix not less. So this is a
Q-fix
new
not
one.
less.
I just see it. We have the straight one. This is a curved one, right?
Yeah, but it doesn't matter. Do you have a straight one?
You are the first one who used that in Thailand.
Straight one?
Oh, you
No.
use the straight one?
Or only this one?
This is a curved one.
มีเอ้ยเดี๋ยวครับเดี๋ยวครับไม่มีเหรอตรงมีไหม
Straight. Oh, this is a straight one? Okay.
Why you prefer the straight one, Hilo?
I prefer straight one because when I insert the anchor,
Yes.
I place the guide here, and then I will press the human head backwards like this to try to the perpendicular to the granite as much as you can. So that's why I don't need to use a curved one. Okay. Count. Drill, please.
ดิว
This is Q fix knotless, right?
Q fix not less.
Okay, go. Softball. Okay.
It's soft, right, Hilo?
ไม่ใช่ไงกันข้อมูลอ่ะ
Rotate. One more. Okay.
2 pop.
Untie. Put that out. Yes. Is it working? Oh, it works nice.
Are you sure?
Is it working?
I don't trust you, Hilo.
Make sure.
It's that strong.
It's working. Okay, great. So now I will make an under super portal. Okay, here. Okay, knife.
Hilo, you didn't use a cannula. No
I don't
cannula.
normally use cannula. I know, I don't.
You don't know how to use it, right?
Can hold
Or you don't like it?
No, I like cannula, but it's not necessary.
Okay.
Oh.
What is all? The blade.
I'll do this.
Careful.
Okay. Oh, it's breaking.
Great.
It's okay. Okay, then can I have suture retriever? Suture retriever.
เจอที่เบอร์ครับ
I retrieve sutures from this photo. Fast mini. Fast mini. Fast mini.
เปิดพาร์ทครับ
That's a little bit complicated. So can I have the grasper? Grasper. So I will use an Acupus. Grasper. Oh, okay. So I want you to pull this tissue up like this. And can I have Acupus?
Acupus.
No, Acupus.
In Thai we call
That's
Acupus.
this one.
ฟังออกหรือเปล่าเนี่ยหนูอะเอี้ยง So Hilo, I heard from your fellow that you have the bone stitcher for Bonnie Bangkok. Did you bring it with you this time?
Yeah. But before using bone stitcher, I need to place sutures to the inferior portion.
Yes.
거기逆だ. The other side. Yes.
ผิดด้าน
Okay. Normally, when I place sutures to the below the fragment, I prefer to use Caspari punch.
Caspari punch. Oh.
History.
This is very old. Caspari punch.
Yeah, but very good
We did
device.
not heard this name long time back.
Okay, like this.
You have
Hold
Caspari
the arm
punch.
here,
Oh
and
my
I want to
God.
distract. Yes.
กับล็อกไว้ให้ผม
Yes.
ไม่ล็อกไว้สู้อะไรกันกดเข้าไว้
Caspari punch.
เรียนไหมเพราะว่าจริงเนี่ยสไปเดอร์
Mm-hmm. Yeah.
Okay.
Passment on.
Yes.
เนี่ยขยายแล้ว
No need to pull this.
Hero, for the first bite, do you sometimes coming from the back to stitch it?
Stitches coming from the front anterior.
Or you do from the front, right?
Oh, it comes.
You're good. Very nice.
Oops.
And sometimes the bone is inside. You can put the suture. Oh, very good. Very nice, Hero.
I found the scalpel.
Right? Nice. The loose body removal. Nata said he left one in the joint.
なんでそんなこと。
So it's Shannon's fault.
Okay, first I will retrieve suture.
Yeah.
Okay.
Go on.
This. Okay, okay. I will do. I will do this. I will do this. It's okay. It's okay. It's okay. It's okay. It's okay. It's okay. It's okay.
ไม่เดี๋ยวเขาร้อยกัน
Retriever, retriever.
With the blue one, right?
All three suture. I need to retrieve.
All together.
Channel, your hand. No, 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 no. Hold the camera, please. Yes. But also this requires. Okay. Retriever, please. Okay. Take this out. Yes. Load this. Okay. Where's the anchor? Oh, here's the sutures here. So I would tie. tie するには OK. Yes. Which is which? Oh, scope is very important now. Instruction, please. Ooh. Uh,
Mm-hmm. Made up.
これ OK なのHonestly speaking, it's my first time to use the Q-fix knotless for this. Oh. なんで
หลุดไหมดำ
มันมีกี่เส้น น่าจะเส้น
ああ、何これ
อ๋อนี่ไง
これこうかけるの
That one.
คือเชื่อแล้ว
Is it working? 何これ。
อันนนท์เปิดแขนหน่อยใบดำหลุดไปแล้ว
อานนท์งัดแขนหน่อยอานนท์งัดแขนช่วยหน่อยเปิดสเปซหน่อยดิ
Can I have this? Can I have no pusher? Not pusher. Can I hold this? Can you hold this?
หลังเครียดได้ไม่ได้เราก็หลุดพอมันไม่มี
これ全然止まんないのこれ。How can I fix this? Do you have another anchor?
Yeah.
I cannot use this. No.
No problem. We can use another. We have enough. Hero.
Yes?
Yes, we have more anchor.
Another one.
Twin fix or something like that. This one doesn't work. これはないの Grasper?
Grasper ครับ มีไหม
Yeah.
ซิงเกิลได้ไหมซิงเกิลมันเด็ก
Yes. All right.
ระวังหัว
Just full?
Suture fix.
Okay, I prefer this. Can I have bone stitcher? Grasper. Okay, I want you to hold like this. No, bone stitcher. Q fix はどういう No. Don't do that too much. Okay. Just a little bit.
So here you go around the bone or go through the bone. This bone
Go
stitcher.
through the bone. I try to go through the bone.
Okay.
Okay.
Nice.
You have Prague. You have Prague? No? No Prague. Oh, no Prague.
Oh, this bone stitcher, you have the eyelet. You have the stylet inside.
Yeah.
That's nice. So there will be no bone block.
You have Prague. No Prague.
What is that?
So we normally use Prague.
Shannon.
Not.
Help.
No Prague here.
มันคืออะไรวะ
ไม่มีเหรอ
Shannon, you know
Prague.
what is that?
No. Prague. We normally use Prague.
The probe, right? Check probe.
Without Prague, very difficult to go through the suture.
ใช่ก็เป็นลวดนั่นแหละ
It's like the Y, right?
ใช่ครับ
No Prague?
เส้นเดียวได้ไหมเส้นเดียวได้ไหมคะ
No Prague?
เอียงมีไหม
No
เอียง
Prague.
Sorry.
Oh.
This
it's
one
very
is okay.
difficult. No, it comes. Very nice.
Ian is very good. Thank you, Ian.
Retriever. Okay. Okay. Hold the camera, please. Okay. Okay. Can I have same anchor?
เครื่องต่อไปตัวเนี้ย
No. No Q-fix. Suture fix, please. Yes.
Oh, Hero, you tie the knot later, right?
Yeah.
Okay.
Yes, please. Okay. Bone stitch again. Okay. Slice.
Oh.
Yes. Shaka. Okay. Retriever.
ยากแกไม่หงุดหงิดนะ
Grasper. To hold the fragment. The grasper. Yes. Thank you. When using bone stitcher, you need to stabilize the fragment.
Yeah.
Using this type of grasper. Then you can penetrate the bony fragment. Normally, fresh fracture is very difficult to penetrate the bony fragment, but this is a cadaver. The bone is a little bit soft, so that's why we can penetrate this. Okay. Yeah. What this? Retriever, please. This one.
So Hilo, for the bone stitcher, how many curve you have? You have left
How many
curve,
curve?
right? Only one curve, right?
Yeah, only one curve. Yes.
No left and right.
60 degree.
60
No left
degree.
hand.
Okay.
Hold the camera, please.
Is that available for sale now in Thailand? The
I
bone
believe so.
stitcher? Yes, right? Okay. Nam say yes. Reusable? Okay, well.
Reusable.
Always sharp, right? Reusable. Very nice.
Okay. Can I have a cannula? I think they're too big. Same, all right? Do you have?
Hilo, you have many sutures, same colors, not confuse you. Confused. The reason that you not tie the knot, why? Can you tell us? Why don't you tie the knot one by one?
Yeah, I place the suture through the bone, two
Yes.
sutures through the bone.
Yeah.
So I tie from the top
The top first.
top suture.
So you use cannula just for knot tying, right?
Yes, yes. What happened? 아, 우리 시단을 또 짰단다. Wow.
What does it mean?
I mistake that. What's happening? Bone stitch again. Grasper. 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 So same suture color is confusing.
Yes. Nó bịตัวแล้ววันนี้
Okay, it is.
So in your practice, how many anchor you put?
Normally 4 anchors.
4. Okay.
River. Okay. Should I hold this? Hold. Just hold. I need to make sure which switch is which. This one. This one and this one. Okay. Okay, okay. Wait. Retriever, please. Okay. Camera, please. This one. This one and this one. Only one, two sutures. Wait, yet. The grasper, please. Grasp. Yes. 잠깐만. Got it.
ตัดไหมตัดไหมตัดไหม
Okay. Dribble. Distraction, please. Okay. This one and this one. Yes. Okay. Thank you. Ah, nice.
Very nice.
Yeah.
So Hilo, you like the suture fix in your practice?
Yeah.
The soft anchor.
Suture fix?
Yes.
Suture fix. I only use suture fix for limb massage.
Oh yeah. So this one you use is suture fix, I think. The anchor.
Well, because they insisted me to use this.
Oh yeah.
Okay, so wait. So I wanna manage this cutter. Retriever.
Hilo, in your practice, when you need to combine limb massage with the bank card, you do limb massage later?
Yeah, I do. How much time left?
มีเวลาเท่าไหร่ You still have time?
Oh, a lot.
Huh?
You have time. And
A lot?
Yeah.
A lot. Huh?
3:20. You have time.
Huh?
3:20.
กี่นาทีอะ
50 minutes. 50 minutes.
Are you sure? You still have nearly 1 hour. 50.
40 minutes?
50 minutes.
40 minutes?
Yeah.
50.
50 minutes.
50? That's
Yeah.
too much.
Yeah.
Too much.
So finish it fast. Yeah, and you can come back.
Huh? Hilo, you have problem with you do limb massage later after you tighten, after you repair the bank card. You have enough.
Yeah,
room.
normally the problem.
Not the problem.
Okay, so you tie the free suture to the second one.
Yeah.
Mhm. Not that way, Hiro. Yes. Very nice.
Okay, I will add one more anchor here
Yes.
to stabilize the labrum.
Uh-huh.
But I think it's okay, right?
You show interval closure. You like to do interval closure, right? I heard that. You have the articles
Front.
about that.
Stick. Switching stick.
What is your indication for interval closure,
Interval closure, okay.
Yes. What is your indication?
Indications mostly.
Most
shoulder
patient.
instability, banquet.
Uh-huh.
This is my bony banquet repair, like
Uh-huh.
this.
Very nice.
Yeah.
Look good.
Interval closures, there's only two exceptions.
Mm-hmm.
One is an older patient,
Mm-hmm.
more than 40 years old. So the risk of the recurrence, risk of creating stiffness is higher than the risk of recurrence.
Uh-huh.
So that's why that's not the indication of interval closure. And then
40.
another indication, other contraindication is the thrower's dominant arm.
Uh-huh. The thrower.
Okay. Yeah. So then I will show you how to do my interval closure.
Yes.
Do you want to see that?
Uh-huh.
Mm-hmm. Okay.
Nice.
So Channon, I want you to free the arm.
Free the arm.
So first, after banquet repair, we need to always check the external rotation like this.
Yes.
There is no limitation.
Nice.
No limitation, right?
Uh-huh.
Then, can I have any suture? No.
You
Suture.
use
Do you have
absorbable or non-absorbable?
free suture?
Free suture.
Free suture. Oh, yeah. Free suture. And also pink. You don't have the, oh, okay.
The pinko.
Akifas. Yes, Akifas. Do you have straight Akifas? Straight.
But big.
Straight Akifas. Okay, thank you.
So Hilo, you prefer the non-absorbable or absorbable?
Non-absorbable.
Non-absorbable.
Suture. So the Lamprey, no. Interval closure is first. I ask my assistant to a little bit internal rotate,
Yes.
like this, maybe 10 degree of internal rotate,
Uh-huh.
and pass through the subscap tendon.
Uh-huh.
Like this.
How far from the insertion, Hiro?
It's maybe about
Just next to
10,
MGHL.
10 to 15 millimeters.
Uh-huh.
Okay. Okay. Then suture. Do you have any suture retrieving device? Suture retrieving device. I prefer to use an pink retriever, but they don't have the.
We don't have pinku. I know you like pinku.
yeah. Grasper, please, grasper.
Yeah.
Yes.
But we have
So
bird
I
beak.
would change suture to the suture. Suture. This one. Okay. Okay. This. Like this. Okay. Now. No, don't put this. Okay. Can I have the Akibas? Straight Akibas? Okay, I want you to bring the external rotation, maximum 60-degree external rotation. Yes. Now my assistant to bring the arm external rotation, 60-degree external rotation.
Mm-hmm.
Then I will try to place sutures through the capsule just behind the biceps tendon.
Uh-huh. You want a big bite, right? You just go above the bicep first?
Yes.
Under the bicep.
Just behind the biceps tendon, capsule.
Yeah.
Then
Some part of SGHL.
Mm-hmm.
okay.
So, Hero, that is the part of supraspinatus, or it's still in the
yes,
interval?
supraspinatus.
The anterior part of supraspinatus.
All right. This suture is too short. This is not a free suture. You have the wrong suture. อ๋อ
เอียงออกมายาวๆหน่อยเอียง
The suture is too short.
Hero, you're so kind, you always laugh. If it's Dr. Natta, he will kill his fellow. He laugh all the time.
Don't mention.
You're a nice professor.
Internal rotation, please, a little bit. We repeat this. Do you have free suture?
เอียงเอาใหม่ให้ท่านอาจารย์หน่อย New one. Don't save the money.เอียงมีเบิร์ดบีกไหมแต่ว่าเบิร์ดบีกมันใช้ง่ายกว่ามี
Okay. Remove this. Do you have suture? This is That one.
Xì này còn béo thiệt. Xì đậm kiếm. Kiếm béo thiệt nha, xì này. Maybe, yeah, there go. And let's see.
Okay. Thank you. External rotation, please. Yes.
But big. ไม่ใช่
Okay. Okay, can you read this? Okay, now we can
Okay.
close the interval. This is the
Nice.
one suture. Normally I use the two sutures.
Yeah.
Okay. Do you have another suture? Can you prepare for this?
Hero,
Mm.
where do you press the second suture when compared with the first one?
More medial.
Now you can a little bit external rotate. Yes.
Where do you put the second suture?
Huh?
Where the second suture.
I normally use the two sutures.
Yes.
One suture doesn't work well.
So the position of the second one is more medial, right? Through the MGHL? I saw it.
Yes, yes.
Yeah.
Yes. Do you have suture? Oh,
So Hero,
nice.
some surgeon worry about the stiffness after the repair. In your experience,
never happens.
never, right? Nice.
Never happens. Because we close the interval with maximum external rotation.
Yes.
So external rotation, please. Don't need to put this.
External, he said 60 degree, right? Of external.
Yeah, more than 60 degree, at least 60 degree.
Okay.
That's very important.
Yeah.
Mm-hmm. Now the most anterior superior corner of the interval, you should grab. Okay, this one. Okay. Okay. So now I
Very
press
nice.
the two switches. So maximum external rotation. Okay. So now I tie the suture. I want you to hold the camera, please. The arm position, you can see the arm position.
External.
It's the more than,
Yeah.
at least more than 60 degrees of external rotation.
Yeah.
I want you to show.
And which one you tie first?
Either.
Okay.
Either one.
No problem.
The most important thing is the external rotation.
Mm-hmm.
And also the incorporating subscap tendon is also very important.
What sliding knot you using?
This is my prefer my navy knot.
Okay.
This is very small knot.
Low profile.
Low profile, yes. Okay, then tie and cut. Show them. Yeah. Okay.
Yeah. Ở trên con.
Okay, this is the after interval closure.
Very nice.
Perfect.
Yeah.
Now we have 20
So this
minutes.
works very well, amazingly well.
Yeah, I agree.
And no external rotation loss.
Yes.
Okay.
Because you did it in big chair position.
Yeah.
Uh-huh.
Very easy to perform
Ekawit cannot
this.
do that. He do it decubitus.
But in Japan, some guys are doing the lateral decubitus in the interval closure.
Oh,
very
really?
successful. Yeah, when performing rotator interval closure, they release the arm from the traction.
Release the traction.
And then bring the external rotation. So then you can do it.
Okay.
Yeah. So ramp research, I think after bunker repair and interval closure, the ramp research pressing suture is very difficult. So that's why I think I will finish my surgery. Is it okay?
That's fine. Sure.
Yeah.
Thank you so much.
Please give a big hand to Professor.
Okay.
Thank you.
Very nice.
Thank you very much. Thank you very much, guys. Thank you. Thank you. I had a wrong usage. I always. That's right.
Okay, welcome back everyone นะคะ I hope you had a pleasant break. The next session will be presented by Professor Ekawit for the slap repair.
Thank you. Welcome back, Professor Sukaya. Why you come back so fast? Whereas Bancha take very long to come back here. Okay. ไม่อยู่เสียบซะเลย Okay, my talk is about slap repair and posterior instability. For slap lesion, I think the overhead injuries is quite rare in Thai because we rarely have the overhead athlete sports. I think it's different from Japan. Japan has baseball, so you have a lot of slap case, right? So in Thailand, I have more case that show up with the anterior shoulder instability. So it's slap type 5. And also the asymptomatic cases, like I accidentally see in the rotator cuff tear. Hiro, how often you do a slap repair in the overhead athlete?
We have so many.
Yeah.
Just two cases a week.
2 cases a week.
Yes.
And what's your rationale for repair or tenodesis?
Overhead athlete throwing injury, athletes in the baseball throwers.
Yeah.
We don't repair the posterior portion. We just repair the anterior superior portion if it extends to the front. The normally slap in the baseball thrower is a posterior oriented, slap type 2 or slap type 8. No extension to the front. So that's the front side. If it's extended to front side, I just repair the anterior superior portion. The posterior side, just debridement. But we have the big data, and also just recently we have accepted the AJSF recently.
Nice.
So that's going to be published.
Okay. So if it's just the posterior, you leave it alone?
No, just debridement.
Just debridement.
Yeah. So because the internal impingement is a problem at this position.
I see. Interesting. But it's much more different to Thai because we rarely have. I do have case like swimmer and tennis player. They may have slap lesion. Okay, because I think this session mainly for introduce the new suture anchor. So main of my talk is about the technique, and I show you the video about the Q-fix knotless later. So there are 2 kind of patient positioning. It be shared like Professor Sugaya, and I myself use the semilateral decubitus on the right. Dr. Bancha may use supine position. For the slap and bankcard repair, I always use 3 portals, except it's extend to the back here. So I add another one. It's called Wilmington portal. Tips and trick. I think the main problem for surgery of the slap lesion is the visualization. Because sometimes if we enter the point very high like this, so you cannot really see the slap lesion. So I recommend to enter the joint really low like this. I show you the video. This one, I enter the joint already and I move my camera to the top part like this. I switch my camera. So you see, this is how I enter the joint. This is 6 o'clock. So this is how I enter the joint, so I can see the slap lesion very clear. So my preference, there are 2 kind of the shape of the superior labrum. One is round shape, the other is meniscus-like. For the round one, I just do a simple suture wrap around like this. You can pass just 1 bite. And then retrieve it and tie the knot. So this is the round type of the labrum, like this. But for the other type is more like a meniscus. So this one, if you do the same thing, it's instead of the meniscus like it will become round. So this one I tend to pass to suture, like the horizontal mattress, like this. I use double load. After I do a knot tying, it may look the same. So you have to make sure that what kind of superior labrum it is. You have to beware about the knot tying. If you tie it too tight, it may end up like a strangulation. And at the beginning of my career, I used 1 bite in the back and in the front between the bicep. And Yeah, and 1 month later, the pop eye shows up. So it's strangulate. So very, very bad to me. And the other about the slab repair. First, it's too tight. Second, if the visualization is not good, you may have tendency to suture the superior capsule altogether with the labrum. So it's make post-op stiffness. That's one thing I think you may have to check. For the posterior instability, it's quite rare condition to me. The symptom of the patient, they come from a small lesion to a very large lesion. The small lesion, patient may show up with pain, subluxation, or someone can demonstrate to you. But for the very, very bad one, it's become locked like this. So because this session is for more like labral repair, so I show you some cases for slab and posterior labral tear. This one I have two combined lesion at the same time. Actually 3. This is slab, very bad, and extend to the biceps. And this is extend to the posterior labrum. Okay. And also have the Bankart lesion. So I start with the slab lesion first. I deep breathe. This one, I just put the anchors and do it side to side repair like this. I repaired for the top one by viewing from the back, and then I switch the camera to view from the top, and I do the posterior inferior labral repair. And now I'm going to repair from the anterior part. But this kind of surgery, you need a knot tying, right? But I think today we have one thing. Okay, I leave it to the next speaker, Dr. Natta. Thank you.
Good afternoon, everyone. Thank you for inviting me to this lovely course. Okay, my talk today is about the glenoid reconstruction, the new thing in Thailand, like a double button. Yeah, I try distal tibial allograft with double button. For me, at first, I would like to share my idea about the options for the adding bone graft on the glenoid. If the bone graft, the bone loss is less than 10%, usually we prefer, or I prefer, the capsulolabral repair only. But the so-called subcritical bone loss, some in the active patient or contact athlete, maybe Latarjet and Eden Hibbinet procedure is now recommended. But for me, this is the point. Some case in subcritical bone loss, they have an overhead athlete. With the Latarjet, maybe it's too much or cannot commit the rotation. In some guys, they lost some external rotation on able. So I think I have a room for the glenoid bone adding on the subcritical bone loss in this kind of patient. First thing. The 25% is open Latarjet is very work well for me. I'm low sensitive for the Latarjet also. So another guys or another option is in even no bone loss in hyperligamentous laxity, in active or in athlete with hyperligamentous laxity, maybe this bone graft, arthroscopic bone graft may be the choice. This is my message today. Two options for the arthroscopic bone graft in these two options of patient. So when you review back to the hyperligamentous laxity, there are a lot of criteria. Usually we use a Biden score, and some institute use the external rotation more than 85. For me, I prefer both. If the Biden score is more than 5, okay, I think about the hyperligamentous laxity. If they are not
enough or not reach the 5 points, looking for the 85 degree or the elbow. If they have an extension more than 10 is also demonstrate that the patient usually have a hyperligamentous laxity. So they have a room of controversy for diagnosis of hyperligamentous laxity for now after review. And result of the bone graft augmentation in hyperligamentous laxity has long time proof with the some option like a capsulolabral plication and the bone graft also. Since 2007, Pascal demonstrate that the bone graft will work, and review for even the last decade, the bone grafts also have a room for the hyperligamentous laxity in shoulder instability. But the thing is significant difference in diagnosis criteria of the hyperligamentous laxity. How do you adjust the hyperligamentous laxity? Dr. Bansha, Hiro, hyper for you. Hyperligamentous laxity patient. I found some shoulder is very loose, but the Beighton score is not more than 5 for me. I use more is like a extension of elbow and external rotation.
You mean at the shoulder, right?
Yeah, right.
So it should be have more than 2 direction, and the main direction is inferior.
I mean hyperligamentous laxity.
Oh, not the MDI, right?
Not MDI.
Yeah, hyperligamentous. We
find
use
some,
the Beighton score.
I find some case they just lack only the upper limb, but not the lower limb. Is quite interesting.
Yeah.
The elbow, the shoulder, but not the knee and the back.
Yeah,
I found a lot.
For shoulder hyperlaxity patient, the bone grafting or some bunker repair, but the adding interval closures very important, I think.
What is your criteria for hyperligamentous laxity in your practice?
It's very difficult to answer. It's
Yeah, right.
Okay, right.
No
So
clear
people-
definition.
Yeah.
People
Agree.
use the Beighton score mostly, right?
Yeah, but I saw a lot of patients
them.
not matched for the Beighton.
Yeah.
Okay. So in this case that I choose a 37-year-old is a gymnastic patient, gymnastic athlete. She also have a many times shoulder dislocation, also the knee patella dislocation also. So the X-ray is quite normal for her. The CT show a on-track lesion, less bone loss, less than 10%. The MRI show a Bankart lesion alone. The slab maybe or not. We did not perform the arthrogram for this patient. She came from other place.
But there's no huge sac lesion, right?
Yeah, no.
Yeah, that's the criteria. Most of these MDI, they have multiple dislocation, but no huge sac.
She had only one direction problem.
Yeah.
From history and from examination. Also, no jerk, no clung test, even EUA. So it is definite anterior instability. Yeah.
No sulcus.
No. Sulcus is positive also.
Yeah.
Yeah, but the posterior is preserved.
But I think when we have no huge sac, most of the time, I think we need to address the inferior part.
Okay.
Also.
I also. And start with a lateral decubitus. So I plan to talk to her about the simple capsulorhabral plication. Maybe you had a 7 to 10% of redislocation. But if I add the bone graft, maybe less than 7 or 5%. So she chose the a low graph. She don't want to lost her iliac crest bone graph. As Dr. Ekowitz said, I prepare for the distal tibial allograft. So I prepare for the set of the Smith&Nephew and saw the animation. I think the first portal is very important because it need to quite low posterior portal and parallel to the glenoid.
Right.
So I put the portal. The first portal is a little bit low from my practice, and also it's also facilitate the slap lesion, as Dr. Ekowitz said. Yeah, you can see. Yeah, you looking from sorry. You're looking from the low portal, and you move like this, so you can see the slap lesion. You have to space a room. I always use the Wilmington portal for slap repair. It's a Thai 2. Yeah, this Wilmington portal. Put the anchor posterior first, and this first anchor I use a knotless. But the second one I use a simple anchor because I would like to tie it. I pass around the labrum first, the posterior leg of the slab, and the other one is pass through the tissue, not around. If you pass around both or pass around, you will put the labrum down and maybe more stiffness of the stiffness also bicep. So I repaired slab first. Right now, I think everyone perform the slab first before go to the capsular level. I mean the bank card. Yeah, and second, I prepare the base for the bone graft. The key is you have to have a suture stitch to manage the labrum, and you need to release till the more than 6 o'clock. And you need to release the capsule from the subscap. Yeah, to make a room for the graft. And this is, you see, the guy should be come to parallel with the guy of Smith&Nephew always perfect straight. I saw is the tip of the K-wire exactly. And you need to clear the rotator interval to pass the graft. We pass the graft through the rotator interval and clear release the rotator interval for the graft passing. And very important for distal tibial graft, the preparation is very important. Dr. Kong Pop come and will help me to prepare, but I think he prepared is so big for me. Yeah, this is a point also. I think with this guy is the hole is a little bit high, so it make the graft is more more angle when seat to the bone. I will discuss later. The key is you need to make the graft trapezoidal shape because the glenoid have a trapezoidal. So if you not match it, maybe the graft may be more angle. So the trapezoidal shape is very important. Yeah, and we prepare the button in the graft first. And then we go back to the, we use some instrument in the set, put the graft to the rotator interval and pull the button. The rope or the button will aid the graft into the previous drill tunnel. Yeah, at that time, they sent me only the one guy. Usually they have two tips of guy, so you can use a double button. Today they give me only one, so I try only one at that date. And then I finish yeah, you see the graph is quite nice, nearly parallel to the green oil. Anyway, I think it's the double button may be better. Is for the rotation of the graph.
But Pascal also used one button.
Yeah, he used a Latarjet. He used just a tip of the Latarjet. It's quite small. At that time, I've been with him. And I finished the rebel, like go far beyond the 6 and from posterior, and I grabbed the inferior pouch with the 2 anchor. I mean the lowest anchor. As Dr. Banchai try to keep, I go from the back so we can more easy to grab the inferior pouch. So for the level of the graph, the graph should be parallel to the green. Now I think the level of graph depend on the degree of the angle of the trapezoidal shape of the graph. If it's matched to the green oil, maybe it's more parallel. And also the pre-drill graph tunnel. In this model, if we come a little bit lower, maybe there is more better for the graph to parallel the green oil. It's 2 things. And this is an X-ray. Yeah. So the key for success: prepare the base of the green oil of the graph, release the capsule until you see the subscap, and usually you go beyond the 6 o'clock, maybe 7. The graph preparing is very important. The trapezoidal shape of the graph is very important. And for the graph pass, you need to have enough skin incision, clear rotator interval, and the button wheel 8. Yeah, as shown in this video, the button wheel 8 is quite more easy for the graph seated in the bone. And button with graph augmentation may be a good option for subcritical bone loss, as I told. Some overhead athlete maybe use a bone graft, like a crest bone graft or allograft in overhead athlete in the subcritical bone loss. Because Latarjet, maybe sometimes you cannot commit the able or extension, they have some loss. And in the hyperligamentous laxity in active and athlete patient may be good for bone graft augmentation. And for me, maybe the pre-op 3D printing will aid for graft matching in the future. Thank you for your attention.
Thank you, Professor Natha, for sharing your expertise. Now we are running to 2 topics, last 2 topics from Professor Sugaya.
สไลด์สุดท้ายแต่นอกจากนั้นเนี่ยผมจะเปิดวิดีโอคิวฟิกน็อตเลสว่าทำยังไงแต่ว่าเขาไม่ได้บอกก็ไม่ต้องพูด
Okay, I will speak about arthroscopic chronic bone bunker repair technique and outcomes. So I want to share this case. 16-year-old boy, rugby player, right shoulder dislocation during the rugby 1 year ago, and repeated dislocation total of 5 times. Physical examination demonstrated range of motion is poor, and anterior apprehension from the 90 degree of the 180 degree abduction and external rotation position. And the CT X-rays still open physis, and the CT scan shows that the bony bunkered region and associated with medium-sized Hugh-Sachs region. So MRI is MR arthrography. Actually, we are doing MR arthrography. Put in the serine inside the joint, and this ABLE view is very effective to assess the humeral head translation, bunkered region, and also the IGH loosening. Okay, so the question is, the 16-year-old rugby player, how many perform bony procedures ignoring bony fragment in this case, for this case? How many? Bony procedure, letter J. Grafting. Okay. And what I did was the arthroscopic bony bunker repair, combined with the Rempel surge and the interval closure incorporating subscap tendon. Okay, this is the Hugh-Sachs region. This is a view from the anterior portal. So first, I inserted the Hugh-Sachs Rempel surge suture placement. This is after suture placement. Now I proceed to the bony bunker repair. I release the bony fragment, and also that together with the labrum all the way down to the 7 o'clock, in this case. This is after release, viewing from the anterior portal. And I repaired the bony bunker. I first inserted repaired the inferior labrum, and then performed bony bunker repair. Exactly same procedure like I did during the demonstration. And also I close the interval with the maximum external rotation. And finally I tie Rempel surge suture. Like this, viewing from the bursa. This is what I did for this patient. And CT, post-op 3D CT, this is pre-op CT scan, 1 month after the surgery, 6 months after the surgery, 1 year after the surgery, 2 years after the surgery. That's a very nice remodeling we can expect. So what is the bony bunker region? The bony bunker region is a chronic renal limb abrasion fracture. The fragment is displaced and migrated to the neck, but connected firmly to the labrum. So this is a typical 3 subtypes of the granular morphology in chronic shoulder instability. We reported only 10% of the normal granuloid, and 50% presented the bony fragment, and the rest of the 40% is the attritional type of the granuloid. And what is the difference of these granular morphology is normally the bony bunker happens in constitutionally tight shoulder, like a big rugby American football guy. You know, they have a very high energy external force impact and break the anterior limb of the granuloid. And after reduction, ends up in the subluxation because the anterior granular limb is already broken, right? And the normal granuloid happens in a very constitutionally relaxed patient. So the very small amount of external force creates a dislocation, but after reduction, Hugh-Sachs region is very small or nothing. And when the granular morphology remains normal. And ends up in subluxation because they are very loose. In the intermediate laxity patient, they create when they dislocate shoulder, they create the anterior limb of the granuloid. So that's why they end up in an attritional type granuloid and also Hugh-Sachs region, and ends up in the dislocator, which requires in the manual reduction after dislocation. Okay, in fact, this is 558 athletic shoulders the consecutive series of 158. Prevalence of distinct bony banker region average is 40%. And interestingly, the rugby, American football players, and also the martial arts and judo and the snowboarder present a very high, little bit higher prevalence of the presenting bony banker region. So how I stabilize it? Yeah, this is a standard my social disability poros, one posterior and one anterior and superior. And I use a posterior poro as a main viewing poro, and an anterior poro main working poro, and the superior poro accessory working poro. And also, important thing is that I don't use cannulas for the anterior two poros. So the bony banker is normally surrounded by soft tissue, so that's why we cannot see the bony fragment directly before releasing it. So that's why pre-op CT scan is very important. And technical parts includes in the extensive complex release like this, and the inferior labrum repair first to reduce the bony fragment upwards, and finally fragment management using a big grasper and a bone stitcher introduced from the anterior poro, like this. So now the big grasper is coming from the anterior superior poro and the stabilize the labrum and the bony fragment, and the bone stitchers coming from the anterior poro and penetrating bony fragment, like this. And, complex release all the way down to the 7 o'clock, like this. And inferior labrum repair first. And finally, I penetrating bony fragment and bony banker repair, bony fragment repair. Like this. This is a view from the anterior poro after repair. Okay, arthroscopic bony banker repair technical powers includes adjunctive procedure. Augmentations are necessary to complement the stability before obtaining bone union and remodeling. So interval closure, including a subscap incorporation, and also limb research in selective cases. So this is a bony banker. I reported the bony banker repair back in 2005 and 6 in JBJS. In 2015, we reported a longer-term outcome study, 5 to 8-year follow-up study, and very nice outcome. Only one recurred 6 months after surgery before obtaining bone union due to major trauma. And otherwise, everybody is very happy and very good outcome. And interestingly, these are example of the representative case. This patient has a relatively large fragment and a very good bone healing, right? And this one is a little bit smaller fragment, but granular morphology improved and almost normalized. We can expect a remodeling after surgery. Okay, the pre-op and the post-op granular bone loss. Preoperatively, the average bone loss granular size was 77.8%. Fragment size was 4.7%. However, 5 to 8 years after surgery, the almost normalized granular morphology, granular size was almost normalized, more than 100%. So why arthroscopic bony banker repair successful? Patients, because one of the reasons the patient's background. Patient with bony banker tends to have constitutionally stable shoulder, and also surgical procedure, the ligament retentioning based on the extensive labrum release is very, very important. So the granular morphology will be normalized in a longer time, 5 to 8 years. So the question is, what about the shorter time? This is an example of the 19 years of sumo wrestler. This is pre-op, 1 month after the surgery, 6 months after the surgery, 1 year after the surgery. Granular morphology improved a lot. And this is another example, 16 years old boy, rugby player. This is actually I already demonstrated. This is the case I demonstrated in the beginning of my talk, in 1 year and 2 years. So the granular morphology will be normalized within 1 year. Within 1 year, almost 1 year. So I think this procedure works very well. So adjunctive procedures for soft tissue banker repair is very, very important. I'm talking about the rotator closure. Rotator cuff and the glenohumeral joint capsule is very close anatomical relationship. Rotator cuff muscles line the glenohumeral joint capsule. So also the inferior pouch is very thick, very thick. So inferior pouch is very thick because there is no lining rotator cuff muscles outside. Actually, this is the surgical images of the humeral arthrography. You can see that here, inferior pouch is very thick, but no surrounding muscles. So, and another opening is the rotator. So why don't we close this opening? So the interval closures, as I demonstrated during my live demonstration, always place suture to the subscap tendon, and bring the arm more than 60 degrees with external rotation, and place suture like this. And normally I use the 2 sutures. Now I'm using the non-observable sutures, high-strength sutures. That's a very, very effective procedure. Okay. So this is my interval closure. Okay, interval closure. So by reducing glenohumeral joint reduction, and also we can induce biofeedback through the restored proprioception by the ligamental retention, which is capsular shift. And Hill-Sachs research is also very important for some specific shoulders. This is the arthroscopic research. Jean Wu presented first during the ANA meeting back in 2004. And they proposed the research for glenoid bone loss and large Hill-Sachs region. But I use this as an augmentation for young, high-risk collision contact athletes. So the posterior cuff, this is a posterior cuff structure, and like this, infraspinatus minor, and I place sutures like this. But I will skip the videos, but I place sutures like this, and place sutures through the direct visualization of the posterior rotator cuff, like this, and I do bunkered, and also the interval closure, and finally, I tie the rempresage suture, like this. Okay, what about the outcome? Let me introduce our 2 papers. This is the arthroscopic soft tissue stabilization for the selective augmentation for traumatic anterior shoulder in competitive collision athletes. We had 113 shoulders with 100 rugby and American football players. Arthroscopic bunker with interval closure only or interval closure plus limb research. Average age at the time, average follow-up was 44 months, minimum 2-year follow-up, and the recurrence was only 3.5%. 93% returned to the pre-injury level. And this is, I will skip this a little bit. And so this is I think the interval closure and the limb research can complement the stability in the early postal period before obtaining bony union. And also the bony bunker in this series, the off-track shoulder was 53%, but this works very well because the bony bunker repair worked for the off-track shoulders. Okay, another study recently published the paper, the judo athlete. So we had 84 shoulders in 78 competitive judo athletes, including 58 males and 20 females. Mean age at time of surgery was 19 years. And 63% bony bunker, exactly similar to the previous study. And arthroscopic bunker repair with the relative interval closure and or interval closure plus limb research. And the mean follow-up was 65 months, more than minimum 2-year follow-up. And we had only 4.8% recurrence and a 93% return to pre-injury or higher level. So to summarize my talk, the patient has substantial size of bone fragment. Morphology will be normalized within 1 year. And to complement the stability during early postal period, adjunctive procedures such as interval closure incorporating subscap tendon is necessary. Limb research should be added for extremely high-risk young patient. Thank you for your attention.
So hello, about the size of the fragment. From your study, you found that when you repair it, the size getting bigger.
Getting bigger.
Uh-huh.
Mm.
How many percent bigger and why it's getting bigger?
I think that because of ligament retention is very important.
Uh-huh.
Not just fragment reduction procedure. At the same, fragment reduced as a result of ligament retention. So then IGHL starts working. Then bony bunker, even if it's small, this works for the kind of epicenter of the bone fragment.
Mm-hmm.
So that's why the the granular size increases. So we reported in 2015 the JBJS and original before surgery 78% only 78% of granular size, but fragment size of 4.7%. But in granular morphology almost normalized, more than 100% after this surgery 5 to 8 years.
Very nice. It's not the osteophyte.
No.
It's a bone.
No. But even if it's ossified, it's happy for the patient, right? Yeah, shoulder stabilized, it's happy.
Nice.
Any questions so far?
So even this fragment is small. Let's say you have 20% bone loss, and this fragment is smaller than 20%. You're still doing that?
Of course.
Yeah.
Yeah.
Okay. So for you, once you have the bone fragment, you always do bony Bankart repair. No lateral.
Yeah. But a very, very small fragment, very big bone loss, and a very young and active patient, I do bone grafting.
Okay.
Yeah.
Thank you.
Can I continue my talk? Okay.
May I ask?
Yes.
Even in very small fragment, can you determine that you can achieve the anatomical reduction of the glenoid?
So
very small fragment.
Very small. I will speak about when the patient has a very small fragment, how I do it in my talk. My next talk. Okay. Yeah. But everybody is talking about bone defect, fragment size, bone defect. But the most important thing is the ligament retention. So that's why when combined with the ligament retentioning and the bone loss, and also the patient's activity, age, so everything, many factors we need to incorporate before making a decision during the surgery. Okay, so my last talk today is the arthroscopic ear grafting using suture pattern system, my experience. So before my talk, I want to tell my treatment strategy for high-level demand athletes. Slow-wise dominant arm, ABR, ABBR only, and intensive physio. I don't close the interval, basically. But in a very lax patient, sometimes I close interval. But majority of collision contact athletes and for this patient, arthroscopic bony Bankart repair or bony Bankart repair with rotator interval closure or interval closure plus lamp research. And abstract shoulders without substantial size bony Bankart, because we cannot rely on the small bony fragments. So that's why I do bone grafting. But in my series, this is very limited, only around 5%. Okay, bone loss in shoulder instability. Engaging Hugh-Sachs region and inverted pelvic is very important, according to the Steve Burkhardt published in the year 2000. And a bony Bankart with medium to large fragment, these shoulders. I think arthroscopic bony Bankart repair works. But bony Bankart with small fragment, if the patient is not so active, like 40, 50 years old lady or something like that, I think bony Bankart repair and soft tissue stabilization works very well. But if the young and active patient, we cannot rely on the small bony fragment to grow, so that's why I do bone grafting. Okay, of course, in larger traditional glenoid without bone fragment, I do bone grafting. So the bone grafting, there are two different types of bone grafting, the coracoid transfer and the free bone grafting. So coracoid transfer, they rely on the sling effect by conjoint tendon. And also the free bone grafting, we need to rely on the capsular effect. So that's why the capsular ribbon reconstruction is mandatory. So my preference for iliac bone grafting with the capsular ribbon reconstruction in order to restore proprioception of the glenohumeral joint. It's a left side grafting, right side bone marker repair. Exactly look like same. So this is specific instrumentation. This is a different company I created in the past. So the first iliac crest bone grafting is like this. I perform like that. I use an anterior inferior portal, and I use a slalom approach to introduce to make a screw hole, make a portal for the screw insertion. So I introduce the graft from the interval and introduce like this, and I make a trans-subscap portal using a slalom approach. That was anterior inferior portal, and then I insert the screw. This is the anterior inferior portal. This is using slalom approach. I try to medialize the conjoint tendon. So this is the for the screw insertion portal, screw portal. Now after this, I did a capsular ribbon reconstruction. After fixation, like this. Okay, the graft precision is critical. Bone resorption or remodeling happens after the free bone grafting. So that's why we had a very good one and so acceptable level on a very poor one. So the screw angle is the issue. So because of the stress shielding of the screw, so that's why the bone resorption occurs. And also because screw head hits the glenoid, humeral head, and also the arthritis happens. So that's why until we stopped using the posterior approach, and I changed the anterior approach using suicide portal, way medial portal. I use that. Terracotta bone is harvested from the iliac crest, and this is the anterior approach. So this is a suicide portal, way medial. Medial side of the conjoint tendon, I created the portal. Graft introduction is the same from the anterior rotator interval, like this. Introduction. And so I clean up the bursa, and then the scope is coming from the anterolateral portal. So we can see the graft like this, and bone suture. Stitching rod is coming from the posterior portal, and now I make a suicide portal, and screw guide is coming through the subscap. This is the anterior portal, and this is the suicide portal, and this is anterior approach of my iliac crest grafting. So the screw position is a little better, but still a little bit perpendicular to the glenoid. So we follow up, we published a paper, the minimum 5-paper follow-up study from 2007 to 2014. 48 underwent the index surgery, and 24 followed for the more than 5 years. Mean follow-up was 8 years. Mean age at the time of surgery was 30 years. And the bone resorption, 13 was excellent, 8 was good, but the 3 was very poor. And the arthritic change is, arthritis, post-op arthritis is inevitable after this procedure. So in the meantime, Pascal published a paper, suture pattern fixation is a safe and reliable alternative to screw fixation. And he reported that the graft healing was 95% and the 93% return to spouse. Only 3% had a failure. So that's why I follow the Pascal's procedure. I first tried the arthroscopic bladder J, 45 revision case with large capsular tear patient. So I use a one-button bladder J procedure like Pascal's doing, arthroscopically. So now, one button, I don't think one button is enough or not enough, but anyway, one button stability is good. The after surgery like this. And bone block, electric grafting, I also started using the bone suture button. So before I use suture button system, I use a suicide portal, other many portals, but now I only use 3 portals. Just very easy, right? So the first time dislocation, the competitive judo athlete, 30 years old, during judo in 2014. Since then, more than 10 times of dislocation. When compared with the other side, he has a severe bone loss. And the bony fragment, he has bony fragment, but this is too small. We can rely on this fragment grows, because he's very active, competitive judo athlete. So that's why we did the electric grafting using button. This is exactly the same as Nata showed. I use a two pair of button system in this case.
They gave me only one.
So graft is introduced from the interval. This is the same procedure. And using tensioner, the fragment. Graft is stabilized very nicely. And after stabilizing graft, of course, I performed the capsule ribbon reconstruction. Okay, so the using button suture system. This is the right after the surgery, and 6 months after the surgery, graft resurfaced a little bit, but still, very good. And 1 year after surgery, a little bit resorption progress, but his shoulder is very, very stable. He's very happy. So I think I'm now following him. Okay, the second case is a 15-year-old girl, right shoulder dislocated by softball throw. After that, 4 times dislocations. Underwent arthroscopic stabilization in different hospital in February 2023. 6 months later, failed without major trauma. After this event, 3 additional dislocations. So she was referred to TSOC in March 2024. And the imaging demonstrated severe bone loss already. Arthroscopic region soft tissue stabilization was planned. And she had not dislocated after the revision, but complained continuous pain. Bone loss progress after my revision, bone loss progress like this. So that's why I did because of the severe bone loss, I did the electric grafting using suture button system. And this is 6 months after the surgery. And she's, right now, she's 1 year after the surgery, she's very happy now, okay? So take-home messages, arthroscopic iliac bone grafting is surgical indications are limited. However, excellent stability can be promised. Bone resorption, probably due to stress shielding and arthritic change by using screws are the concern. So that maybe the use of suture button can be a future choice. Thank you for your attention.
Thank you, Professor Sugaya. Any questions?
Yeah. You now you have experienced both button and the screw. So in your experience, do you think the healing potential is same or different?
I think same.
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 And how about the gap resorption? I saw you have some gap resorption in the screw.
So sometimes in the screw, in some shoulders, maybe, more than expected, the bone resorption very rapidly happens. 6 months after the surgery, maybe 80, sometimes 80% of the bone tissue disappeared, but the screw remains. So that's why his shoulder is very stable.
Yeah.
So that's why I don't like screw fixation now. I like
You stop
pattern
it now,
fixation.
right? You stop it.
Pattern fixation is more, more natural, I think.
Yeah. Thank you.
Any questions?
You think we need 2 buttons or just one? Like Natha have
Free
one.
bone grafting, I think we need two pair of the button is better.
How about Latache?
Latter if the patient has a big crocodile, like Caucasian guys, maybe two sets, but the Japanese or Thai people, small crocodile, one set's enough, I think.
Okay.
Yeah.
Thank you.
Thank you so much, Professor Sukaya. And this brings us to the last session. So for our faculty member, do you have any take-home message where the participant can apply to their own clinical practice?
David?
เอกวิทย์ครับ
So no any more question? Please. It's very difficult to have leader come to here. So please ask more. Are you sleepy? What's your difficult part for the bony bank card? Oh no, sorry, the bone block procedure. What do you think is the tricky part or most difficult part, and would like to share to us?
The jig that Pascal created, that's not enough. I think the jig cannot stop the tip of the jig is kind of flat. So this is just moving. So that's when once we purchase the good position, but it moves. So sometimes in the screw position is not ideal. So that's why I'm now making my own jig with a very sharp tip. Yes, that's the hardest part. That's the only hardest part. Otherwise, if you can prevent the tangling of the suture, that's very easy. I think it's much easier than the screw fixation.
How about the passage of the free graft? You prefer through the muscle or through the interval?
Interval.
Better, right?
So Hilo, one question about how to make it parallel. Yeah, that's sometimes not easy. To make it parallel to the native cartilage.
Yeah. So
is that a bit proud you clean it with burr or not? Or you?
That's also, I think, the jig issue.
Yeah, jig issue.
Yeah, jig issue.
And your graft, you make it like that, make it like trapezoidal, or you make it rectangular? The graft.
It's a graft is I'm using ear crest.
Okay.
Ear crest, yes.
So it's a bit like rectangular, like I saw in your.
Yeah, and I always check the pre-op 3D CT, and I shape to the defect. So then it fits well. Right.
Shape the defect to match with the graph.
Yeah.
And how about the subscap? The difficult of the latarge arthroscopically is a subscap open. You need to pass through the subscap. How about this set? I mean, latarge set for the open the subscap.
Yeah, that is the most important, most difficult part of the arthroscopic Reta J. But I'm using the Pascal's device, opening, subscap splitting device.
You usually should have a posterior one and anterior one for the subscap open, right? I'm not sure.
I know from the posterior open and from the anterior open.
You have two. Also, you bring only one, I think. I saw only one in your set.
I think the only one is very difficult.
Yeah.
Yeah.
So I think today we learned a lot from you, and also we know more details about the regenitent, right? So I think for the audience, now you know the indication to do the regenitent and a lot of sharing from the experts, right? So I think at least you know the indication and also the benefits of this patch, okay, for me. And also, thank you so much for your sharing in the instability case. Yeah. Natha, any last word for you?
Oh, for me, my idea is my point is my talk. The two options for young guys. Man, you can add bone graft with this test is I think is quite more easy. When you are you know the portal and you can clean the rotator interval. This guy will aid, and the suture will aid the graft to the posterior part or anterior part of the glenoid. It's much more easy than screw previously, I think.
Yeah, I agree.
I agree.
Any last word from our Chanon, Tim, and Poom? Yeah, just short message. Tim.
If no, that's okay. No problem.
Not now.
Okay, I think
Okay, good.
we all have a very good time with you guys, and thank you, Smith and Nephew, for the wonderful 360 meeting today, and hopefully all of us can learn more and share a good time like
I
this.
thought about a 360 fast fit.
Master class.
Okay.
Not the knee, the
Thank,
shoulder.
thank you, everyone, and have a safe trip back.
Yeah.
Bye-bye.
So you still have dinner here, right? Please announce.
Okay, before ending the session, I would like to have your feedback survey for this course to improve our further events.
Very nice talk.